Good morning, dear ladies and gentlemen. A warm welcome to all of you to today's webinar organized by the Society for Health, Research and Innovation. So moving on to the topic, smiles on the lifelong impact on the timely orthodontic care. We have a well-versed resource persons today with us. Hope you all know by now, Dr. Amirtavarshini Rajaganeshan and Dr. C.N. Gunathi, sir. Dr. Amirtavarshini Rajaganeshan, a distinguished expert in the field of orthodontics. Currently, Dr. Rajaganeshan serves as a senior lecturer in the orthodontics at the Faculty of Dental Science, University of Sri Jayewardenepura. Dr. Rajaganeshan's academic credentials are impressive. Having graduated with a BDS from University of Peradeniya, she further specialized in orthodontics, obtaining her MD in orthodontics and becoming a board certified in 2013. Her expertise was further recognized internationally with her membership in orthodontics from Royal College of Surgeons, Edinburgh in 2014. Dr. Rajaganeshan gained a valuable experience as a consultant orthodontist in various institutions, including District General Hospital Shillong, District General Hospital Nigambu, and Teaching Hospital Kalutara. And I am here to introduce Dr. C.N. Gunathi, sir, a highly esteemed specialist in orthodontics. Doctor graduated from Faculty of Dental Science at the University of Peradeniya. She further education with a postgraduate degree in MD Orthodontics from the Postgraduate Institute of Medicine, University of Colombo in 2013. Dr. Gunathi, sir, was board certified as a consultant in the orthodontics in 2014, demonstrating her expertise and commitment to deliver exceptional patient care. To expand her knowledge and skill, she underwent overseas training at the renowned Northwick Park Hospital in London. Additionally, she holds a membership in orthodontics from the Royal College of Surgeons, Edinburgh, which she obtained in 2016. Through her career, Dr. Gunathi has gained valuable experience working in various esteemed institutions, including Teaching Hospital Batticaloa, General Hospital Shillong, and Teaching Hospital Ratnapura. We are honored to have Dr. Gunathi's expertise and dedication to the field of orthodontics. Thank you, madam. Let's now go for the session. Have you ever wondered how a beautiful smile can impact your life, not just aesthetically, but also in terms of confidence, self-esteem, and overall well-being? Today, we'll explore how orthodontic care at the right time can have a lifelong impact on your smile and on your life. Without further ado, please join me in welcoming Dr. Rajaganesh, who will take us on a journey to discover the power of timely orthodontic care. Over to you, madam.
Thank you very much, Dr. Afka, for your kind introduction. So I will be sharing my presentation. Right, I hope all of you can see the screen. So a very good morning to everyone who has joined. So in this presentation, we will be taking you through and highlighting the importance of recognizing and treating orthodontic problems at the right time. So we'll be looking at various developmental stages, the common problems and the treatment options available, and how early intervention can save time and cost and also improve the quality of life. So as medical officers and healthcare professionals, we have a duty to identify things early, therefore it prevents complicated treatment later on. In dentistry, just to give you a brief outline, dentistry has 5 specialties. So under the PGIM, you can do postgraduate studies in one of these 5 specialties to become a consultant. And so the specialties are oral pathology, community dentistry, restorative dentistry, oral maxillofacial surgery, and of course, orthodontics. So when it comes to orthodontics, what exactly it is, I'm sure most of you know. It's a specialized branch of dentistry, which is focused on diagnosing, preventing, and correcting malaligned teeth and jaws. So an opposite orthodontist is a dentist who has completed postgraduate training and has qualifications in the field of orthodontics. So we're going to look at briefly at what are the benefits of orthodontic treatment. So there are various multifaceted benefits. The main one is aesthetics. So it enhances one's smile, and it can boost the self-esteem as well as the confidence of the individual. And functionally, yes, it does improve the way people bite. It improves chewing as well as speaking as well. And oral care becomes easy because aligned teeth, teeth which are well aligned, are easier to clean. And therefore, it reduces the risk of decay and gum diseases. So the benefits of orthodontic treatment are quite numerous. So when you look at this photo, just let me know what you notice first in this picture. So I don't know if you've seen this before, but I'm pretty sure most of you would have spotted a missing tooth in the man. But did you also notice that he has a missing eyebrow? Right, so it's interesting to see how our attention is drawn to certain features, especially the smile, where other features can be easily overlooked. So that explains how shows how prominent and socially impactful a dental appearance can be for an individual. So the power of a smiles are universal. It is the second facial feature after the eyes that people tend to look at when evaluating facial attractiveness. So a confident smile does help to enhance communication, self-esteem, and social interaction. And orthodontics can enable individuals to smile with confidence. Now come to a term called malocclusion. So malocclusion refers to imperfect or irregular alignment of teeth. According to studies, there's a worldwide prevalence is around 56%. So, according to WHO, malocclusion is considered to be the third priority for oral health diseases. So you can see there is a significant population who do have various types of malaligned teeth and jaws. Orthodontics is not just about cosmetic treatment, it is way beyond cosmetic, though certain significant proportions of problems are cosmetic, but it has the scope goes way beyond cosmetic because it is proved that there's a negative effect on psychic and social well-being, which can result from dentofacial disfigurement. And those who look different are treated differently and may face discrimination as well. So treatment to overcome social discrimination does not come under cosmetic treatment. So it's not vain or irrational to desire an improvement in facial appearance that can improve your total quality of life. So brief look at the history of orthodontics. Orthodontics is a relatively new field. It was identified as a new branch of dentistry by someone called Edward Angle in the 1890s. So who is referred to as the father of orthodontics. Not only that, orthodontics can date back to ancient civilizations as well, like before even the term came into practice. The desire to have nicely aligned teeth went back to even ancient Egyptian civilizations. And the Egyptian mummies were found to have metal bands around the teeth. And even Hippocrates has referred to dental irregularities in his writings dating back 400 BC. So in order to correct the problems that we see, the alignment in the teeth as well as the jaws, we have various gadgets and appliances available to us today to be used. And these I have mentioned here some of the appliances. So there's a removable appliance which is made out of acrylic, and it can be worn and removed. We have fixed appliances which are glued onto the teeth, and there are growth modification appliances which like the functional appliance, as well as headgears which work to alter the way the skeleton grows, and of course aligners. So before we move further, just to get a brief idea, I would like you to respond to this question in the chat box if you like, or you can unmute yourself and answer. Which of the following problems you think would need early treatment? should be identified early and treated early. So I'll give you about a minute. Most people have said A. Some have said C. B. All right. Thank you for responding. I think most of you have gone for A, but people have said B and C as well. So I'll tell you the correct answer, and as we go on in the lecture, you will understand which needs early treatment. So actually, the correct answer is C, the last photograph. Right. So here you can see a variety of malocclusions which affect the teeth. So there are several dental irregularities. Teeth can be too forward. You can have extra teeth. Teeth can be spaced. The way this is called a crossbite, the way people bite is wrong. And here there are gap between upper and lower teeth is called an open bite. There are various problems people come seeking treatment. But not only teeth, orthodontics deals with problems in the way the jaws relate to each other. So not just the teeth being irregular, children can have maybe the upper jaw being too forward or lower jaw being too forward, or else upper jaw is not grown too much or lower jaw has not grown to the extent where it should. So these are jaw discrepancies which can be treated as well. So before we move on, I'm going to talk about the cause of these malocclusions. So malocclusions do result from complex interaction among multiple factors. These factors can influence the growth and development, and they can be caused by genetic as well as environmental factors. So certain types of malocclusions do tend to run in families, like mandibular prognathism, meaning the mandible has is growing more than it should compared to the maxilla, and also something called a long face pattern, where the maxilla grows vertically more than it should. So these kind of growth patterns do tend to run in families. Uh, Genetic, their cause is genetic, whereas certain environmental factors, certain habit-related issues like, children with thumb-sucking habits, children with mouth-breathing habits, and the tongue posture do also lead to malocclusions. So identifying and modifying these early can also prevent severe outcomes. So this is just a fun fact. There's a strong example of genetic control of dentofacial deformities. So having a prominent lower jaw was referred to as Habsburg jaw. I don't know if you have heard that term. It's termed Habsburg jaw because it was seen in the European royal family who ruled around 16th to 18th century. So because of continuous inbreeding, everybody in that family, Habsburg family, had prominent lower jaw. So therefore, it came to be known as Habsburg jaw. Right. So before we decide which orthodontic problems need early treatment, it's important to understand how the teeth or the dentition develop over time. So we should be able to recognize what is the normal path of development, what features are red flags and that need to be intervened early, and which ones can be safely left alone for now, but will need treatment later on, maybe when the child is older. So to make sense of this, we break the dental development into three key phases. So we have a deciduous dentition phase that is up to 6 years when the child has all milk teeth. And we have a mixed dentition phase from 6 to 13 years of age. This is a critical phase. That's where both baby teeth as well as permanent teeth are coming into the mouth. And a lot of changes are happening. A lot of growth is also happening. And it's the best window to catch and correct problems early before the problems become severe. And then we have the permanent dentition phase, which is 13 years and older. Around the age of 13 is where all the baby teeth have fallen out, and you have a full set of permanent teeth in the mouth. And comprehensive orthodontics, that is, can usually begins at, we do it around this age. So each of these phases do come with a set of concerns and treatment windows. And we will see that in the next few slides, what to look for in each of these phases. So first, deciduous dentition phase is like I said, it's called the primary dentition or the milk teeth up to the age of 6. So there are 20 milk teeth in the mouth, and all 20 of them would exfoliate at various times during the development. And usually we don't do any orthodontic treatment at this stage, but it's very, very important to maintain the deciduous teeth in the healthy form, because they are the ones who maintain space for the permanent teeth to come into the right position. If in case a deciduous tooth is lost before the time it should exfoliate due to caries or due to trauma or any of those reasons. So here you can see photographs of deciduous dentition where these are all milk teeth. And having spaces between the milk teeth at just about the age of 5, it's a normal finding. Parents do tend to panic when they see this, but this is a normal finding because this spacing helps for the permanent teeth to come into the right position, because permanent teeth are larger than the baby teeth. If the baby teeth are lost early before it is time for them to fall, then it can lead to problems like these. It can lead to crowding. You can see here, there are these, this is the permanent dentition. And because the child has lost the deciduous tooth early, the space available for the permanent tooth to come is lost. And therefore the permanent tooth has come in the wrong place. So, now this child will require extensive treatment to align this issue, whereas this could have been prevented if it was by simple methods. So soon as the deciduous tooth is lost before its correct time, the space closure, I mean the other teeth can drift into the that space and close the space as early as 6 months, especially in young children. Therefore, that's why it's important for us to act quickly and place a space maintainer in certain children. The space maintainer is an appliance which is fixed onto the teeth. It maintains the space. It prevents the other teeth from drifting into the extracted zone and maintain the space and keeps it until the permanent tooth is ready to erupt. So these are called space maintainers, and it preserves the arch length and keep the space open. Without it, the neighboring teeth will drift in and close it, leading to the permanent tooth which is supposed to come can come to the wrong place, or even worse, it can be stuck inside the bone, which warrants surgical removal later on. So doing something like this is very simple and effective, and it prevents expensive treatments later on. So now we will moving on to mixed dentition phase. Mixed dentition phase is lasts from around 6 to 13 years of age. And I said it is a critical phase because children will have 2 sets of teeth in the mouth. So you all know humans are diphodont. It means we have 2 sets of teeth. We have a deciduous dentition phase and a permanent dentition phase. In between, we have mixed dentition phase. So the mixed dentition phase is a transitional phase where both primary and permanent teeth are present in the mouth. And during this time, baby teeth are falling off and permanent teeth are coming into in the mouth. So this gives us the greatest opportunity to intervene, to prevent and guide the teeth into the jaw development into the right position. If there are any harmful habits, we must intervene at this point and correct the emerging issues before they become more complicated. So during this phase in the mixed dentition, we can see various issues. Certain problems are transient, they're part of growth, they correct on their own, so we don't need to intervene. And there are certain dental irregularities which need to be corrected. And also there are certain jaw discrepancies which are best corrected during this phase. So we look at the transient problem. So this photograph you would have seen in the quiz that quiz slide I showed earlier. So this finding in the mixed dentition phase, you see around the age of 7 to 9 years, when the child has the four here are permanent incisors, whereas the rest are deciduous teeth. The permanent teeth, like I said, are larger than the baby teeth. Therefore, when they come into the mouth, they will not be able to come straight. They will be slightly irregular. But as the child grows older and the jaw gets wider, these crowding will sort themselves out on their own. So we don't need to go in and do something at this point. A lot of parents do panic when they see this. My child had a lovely aligned baby teeth, but now when new teeth are coming, it's all irregular. But all we do is we just reassure them and say, no, this is part of the normal development. We don't have to intervene. As a child gets older, these minor irregularities do get sorted. But severe problems, we might need to intervene later. But such mild problems do correct on their own. Therefore, we don't need to have early intervention for this problem. Next, another problem you see in the mixed dentition phase is something called the ugly duckling stage. So this is something we see between the age of 8 and 10, where a lot of parents again do become concerned when they notice space between the two front teeth. This is called a median diastema. This is again part of normal development. When they see this space happening, parents do get concerned and they bring the child. So this spacing is actually non-common and often is caused by if you can see in the next picture, the eruption of the permanent canines. And when it hits the root of the lateral incisor, it causes flaring of the incisors, leading to this diastema. So as the canine comes down and erupts into the arch, the spacing and everything settles on its own. So this is called physiological diastema, and also people refer to this as a ugly duckling stage because it looks unusual and parents do get worried. So in these cases, we just educate and reassure the parents and say that there's no need to intervene at this point, but we will monitor to see if the permanent canine does come down normally. Therefore, no orthodontic intervention is needed for this issue as well. Next, starting around the age of 6, the baby teeth start falling one by one at various times. If the baby teeth doesn't fall and the permanent tooth erupts before the exfoliation of the baby tooth, it is called a over-retained tooth. And this, of course, intervention is necessary because if there's over-retained baby tooth, it can lead to deflection of the path of eruption of the permanent tooth. Worse, the permanent tooth can be blocked inside the bone and remains unerupted. So such cases, yes, we do have to intervene early, remove the baby teeth as early as possible. And once you remove the baby tooth, the permanent teeth will automatically come into the right place in certain cases. In certain cases, we may need to fit an appliance to bring the tooth into the right position. So such instances, yes, you do need to have early intervention. Next, we're going to talk a little bit about oral habits and how they cause problems. So habits such as the non-nutritive sucking habits are common, and they do become problematic if the habit is prolonged. So thumb sucking, digit sucking, especially continued beyond the age of 5 and 6, can result in severe dental irregularities as well as distorting the jaw growth and as well altering the tongue posture. So here you can see the problem. This is purely the photo you see to your right. This is purely due to the thumb sucking habit where there is a large anterior open bite, which is asymmetric depending on which hand the child is sucking, whether it's right or left, you see an asymmetric anterior open bite. And narrowing of the upper jaw caused by negative pressure. And here there are irregular bites as well. This is called a cross bite. And all these problems due to this prolonged thumb sucking or digit sucking habits. So these are some of the features you tend to see in a child who has a thumb sucking habit. And how do we intervene? So it's very important to break the habit, but we don't start off straight away with the appliance. Uh, Sorry. So first what we do is a non-dental intervention. So you counsel the child, talk to the child, have a discussion, and you can like, waterproof tape around the thumb, or a reminder therapy or reward system, or have an elastic elbow guard where they cannot bend the elbows in the night unconsciously to suck the thumb. So those are non-dental interventions we always try first thing, and give the child just information and try get them to stop on their own. So child is important for the child to understand that this is not a punishment, and you to make them understand that what you're doing is causing problems to your teeth. So so even with that, the habit doesn't stop, but the child is willing to stop. And then we can start with appliance therapy. These are, you can see in the photographs below, these are habit breaking appliances. So they can be glued onto the teeth with cribs placed in the anterior region that prevents the child from placing the thumb inside the mouth. So as soon as the appliance is fitted, children tend to stop the habit, but we do continue the appliance for a period of 4 to 6 months to make sure the habit is completely stopped before removal. Fitting this appliance early before the age of 9 is important because that helps spontaneous correction. So once you fit the appliance, the anterior open bite, the teeth sticking out tend to correct on their own. But beyond the age of 8 and 9, that becomes difficult because then the eruption potential of the teeth are gone. Then if the habit is continuing beyond the age of 9, in addition to habit breaking therapy, we will have to start proper orthodontic treatment to get the teeth into the right place as well. Another feature you tend to see in the mixed dentition phase is extra teeth. So these are teeth which are in addition to the normal series of baby teeth as well as permanent teeth. So these are called supernumeraries. So sometimes they erupt right in the middle. These are called mesodents. Because the extra teeth, we have to take them out as soon as possible and allow this space to close, and therefore give enough space for the other proper permanent teeth to come into the arch. Supernumerary teeth can also cause various other problems. Here in the second photograph below, you can see it is preventing a permanent tooth from coming into the right place. So here is over-retained deciduous tooth, whereas on the right side, permanents have erupted, and this tooth is blocked by a supernumerary. So such instances, we have to intervene as soon as possible, surgically remove the supernumerary, expose the unerupted tooth, and pull it down, gradually pull it down during using orthodontic traction. So it's important to know supernumeraries may not always be single. There can be multiple supernumeraries. In the last picture, you can see there are two supernumeraries. One is about to erupt and the other one is inverted. So when we see a supernumerary, we will always investigate with an X-ray to check whether there are multiple unerupted supernumeraries present. So this photograph, again, I showed in the quiz. So this is something called an anterior crossbite. So this does need early intervention. As soon as we see it, this has to be corrected. Why it has to be corrected is, you can see here marked by the red arrow, the bite is wrong. Usually the upper teeth bite in front of the lower teeth, whereas if it is the other way around, is called a crossbite. And this lower incisor, which is small, is not designed to take a lot of trauma, occlusal trauma, in this way of biting. Therefore, this incisor, permanent incisor, can undergo severe periodontal breakdown and the teeth can become mobile and child can even lose that permanent tooth. Therefore, as soon as we see a crossbite, this has to be corrected. So here you can see a corrected crossbite. And this can be done very easily with a simple removable appliance, and that's the active component is called a Z spring. And if instructions are followed, it can be corrected within 1 or 2 months. Crossbites you can have in the back teeth as well, posterior teeth as well. The problem is when there is a crossbite in the posterior teeth, it can lead to something called a mandibular displacement. So the child can't bite properly and constantly shift the mandible to one side, leading to facial asymmetry as well as temporomandibular joint problems. So posterior crossbites also, as soon as we see it, even if it is in the mixed dentition stage, it has to be corrected. So normally we can correct posterior crossbites by using one of these appliances. So these are removable appliances, and the one on the right are fixed appliances. These are expanders used to expand the upper arch to get the teeth out of crossbite, therefore stopping the unwanted mandibular shifts. So here's an example of buccal crossbite, posterior crossbite, and what you see in the middle is this appliance is called a quad helix appliance fixed inside the mouth to expand the upper arch. And here you can see with the crossbite corrected, and the patient is on fixed appliance for other minor irregularity correction. Another important features we see in the mixed dentition stage, which immediately requires attention, is impacted teeth or buried teeth which are buried within the bone. So here's an example. You can see here the permanent tooth is there and it is blocked by a structure here which doesn't look like a tooth. We call this an odontome. It is made of tooth materials, but it doesn't exactly look like a tooth. So this has to be removed, and then the permanent tooth has to be brought down using orthodontic treatment. So in this X-ray, you can see the orthopantomogram of a child in mixed dentition. So there are several permanent teeth erupted, several baby teeth which have not erupted. And we do this to see whether the permanent canines are in the right place. So permanent canines are the last teeth to come into the mouth. Therefore, they are the ones who tend to get impacted or tend to get buried. So it's highly complicated when the permanent canines are buried inside. So we have to screen the children around the age of 9 to make sure the permanent canines are in the right path. So here you can see this is an older child around 14 years of age. He presented late with the permanent canine on the right side gone totally wrong. Here you can see the overeaten deciduous baby canine here, and that's a permanent canine. On the left side, it's already erupted. So this is a clinical photograph as well. That's a baby tooth. And the permanent canine is stuck in the palate. So because the child presented late, we had to do surgical exposure. So remove the baby tooth, expose the canine surgically, and it was a complicated process to bring it into the correct alignment here. So this such lengthy and surgical treatment can be prevented if we did identify it early. So here this was the same patient after the canine was brought into the correct position. But we can prevent these kind of problems if we catch the children early, especially around the age of 9. Just when the we can feel to see if the canine is in the right path, like you can see here, they are feeling the labia sulcus. And according to a very famous study, they reported that around the age of 9, 10, 11, if you screen the children and find out the maxillary permanent canine is going the wrong way, at that point, if you remove the baby tooth early, it can allow 91% of the time the canine will normalize and come down on its own without any intervention. Even if it has shifted significantly beyond its path, it still has 64% of chance of normalizing and coming into the right path. So this is very simple. Just removing a baby tooth will allow the canine to normalize and come down. Whereas a child we saw earlier who presented late, the baby tooth, the problem was not identified, it was missed. Baby tooth was not removed. Therefore, the canine continued to go the wrong way, which warranted complicated treatment. In addition to that, around the mixed dentition stages, children can present with various other issues as well. So larger teeth, small size teeth, and teeth which are fused. So I'm just giving examples of, these are rare conditions, but yes, we do see them. And finally, before I hand over to my colleague here, we're going to look at another problem which needs early intervention. So this is called severely procline incisors. These children cannot close their lips. So the lower lip lies behind the upper teeth, so the upper teeth are exposed, and therefore there is a risk of trauma. So if they do get into during sports, or if they have a fall, teeth are the first thing that hit the ground. Therefore, there's chance of fracture of the incisors, and these are permanent. Therefore, the later on the treatment process becomes complicated. Therefore, it is indicated to treat these children early, get the incisors to get behind the lower lip. Therefore, upper incisors are protected. So they are in mixed dentition phase. That means, normally orthodontic treatment we start after the age of 13, but such children we can justify doing early treatment even at the age of 8, 9, 10, because of the risk of trauma, and because some children may have issues with self-esteem, or whether they're being bullied at school because of the way the teeth look. So due to these reasons, we do treat such children early and get the incisors behind the lower lip to have protection. So with this, I'm going to conclude my part of the presentation. So we looked at the transient problems as well as the dental irregularities we see in the 6 to 13 years mixed dentition phase. To continue with the skeletal problems, I'm going to hand over to my colleague, Dr. Niroshana Gunadisa, to go ahead. So thank you very much.
Thank you, Dr. Amitavarshini Rajashekhan, for your enlightening lecture. Your expertise and insights have truly been valuable. Your presentation has equipped us with the knowledge to identify and recognize red flags that require timely intervention. By doing so, we can make a significant difference in the lives of our patients and help them achieve optimal oral health and beautiful smiles. Now, I would like to invite Dr. C.N. Gunathi sir, Consultant Orthodontist, Institute of Oral Health, Maharagama. Over to you, madam.
Thank you, Afka. So we have been looking at the problems that we need to address during the age of 6 to 13 years. So I will be starting this part of the next part of the lecture by looking at the skeletal discrepancies that can be addressed and should be addressed during the mixed dentition phase. So if we see skeletal discrepancies, we have we will have skeletal discrepancies in all three planes, that is anteroposterior plane, the vertical plane, and the transverse plane. So when we take orthodontic treatment, all of the orthodontic appliances can be widely categorized into three major treatment modalities, that is growth modification, orthodontic camouflaging, and orthodontic surgery. So what do we identify by growth modification treatment is where growth modification is where we try to alter the growth, try to alter the skeletal pattern, the growth of the skeletal pattern or the skeleton during growth to correct the underlying skeletal discrepancy or the underlying malocclusion. By orthodontic camouflaging, what we mean is where we try to mask the underlying skeletal discrepancy by moving the teeth along so that the patient will have a pleasing profile. And finally, what we mean by orthodontic surgery is when the skeletal problem is too severe or when the patient is too old, for adult patients, where we cooperate with the maxillofacial surgeon to correct the jaw discrepancies with a jaw surgery. So if you can remember, craniofacial growth also follows the cephalocaudal growth pattern. So we do have a window of opportunity for growth modification for patients with skeletal problems during growth. So if you can remember your growth charts, we do have what we call a pubertal growth spurt. And this is the timing where we usually try to go and attempt skeletal discrepancies. So it's important to identify which skeletal discrepancies can be addressed and which skeletal discrepancies needs to be referred for early treatment. So moving back to our anteroposterior relationships in the skeleton. So this is where you see a class 1, what we call as class 1 skeletal pattern. If you see this girl has a straight profile, the mandible is slightly behind the maxilla, about 2 millimeters. So this we call a class 1 skeletal pattern in the anteroposterior plane where we consider this to be normal. We have class 2. Class 2 is when your maxilla is lying far forwards, or where your mandible is lying far behind the maxilla. So you would see, sometimes you would not, it's important to identify which jaw is at fault when we are attempting correction and especially treatment. So growth modification treatment is attempted, can be successful for patients who have mandibular deficiency, and also for patients who have maxillary excess as well. So this is a patient who was treated with growth modification treatment. We use what we call a functional appliance. The functional appliance could be a removable appliance, a simple removable appliance like you see on the picture on the bottom left, or a fixed appliance. This is called a Herbst appliance. It's a fixed appliance for less cooperative patients where we are attempting to correct the jaw discrepancy. And if you can see on the top photograph, you can see the change of the profile simply by using the appliances we have mentioned below. So this is a similar girl. She had a class 2 skeletal problem, and if you can see, her mandible was slightly lagging behind. So this is after treatment. So we treated her with again a removable functional appliance. So if you can see her intraoral photographs. Sorry. If you can see her intraoral photographs, so she had what we call proclined incisors and her mandible was lagging behind. So by giving the appliance, you can see the end result, which was actually acceptable, and she actually does not need a course of fixed appliances as well. So if you to emphasize on when the skeletal problems, especially the class 2 problems, should be addressed, we usually try to start during the pubertal growth spurt. That is where we can get the mandible to grow, and also for if the maxilla is in excess, we use an appliance called the headgear to correct the skeletal discrepancy. So moving on to class 3 class 3 in the anteroposterior plane is where we see the mandible is jutting out, or when the mandible is far forwards than the maxilla. This again could be due to a prognathic mandible where the mandible is far forwards or the mandibular growth is high, or it could be 25% of the time it's because when the maxilla is lagging behind, or we call it maxillary retrognathism, or it could be a combination of both the retrognathic maxilla and a prognathic mandible. So for prognathic mandible, it's like Dr. Varshi mentioned in the beginning of the lecture, it's actually a genetic, there is a genetic component for prognathic mandibles. So growth modification treatment attempted at class prognathic mandibles are not very successful. However, if we identify which jaw is at fault, for that we have to ideally take a cephalometric X-ray. And if we see a retrusive maxilla, we can give an appliance called the reverse pull headgear, where we attempt to bring the maxilla far forwards. So what you have to remember in such situations is, whereas for class 2s, we wait until the pubertal growth spurt to start the treatment. But whereas if we identify that the maxilla is at fault, for a class 3, we need to start treatment slightly before this. Ideally, the patient should be directed to us at the age of 7 to 8 years. So you see this girl wearing a reverse pull headgear. So this appliance, the patient will be wearing this for 12 to 14 hours a day while the child is at home for a period of about 1 year. And if you can see the differences in the first photograph and the second photograph, you can see that we have achieved the maxillary growth, and we have been able to bring the maxilla forward. So evidence says that for maxillary retrognathism, 75% there is a 75% chance of long-term success, because if we don't identify these patients during this window, then we not be able to treat these patients with simple fixed appliances alone. We will have to wait until the child attains adulthood, and then the child will have to undergo what we call an orthodontic surgery. So evidence suggests that, starting reversible headgear treatment at the right age could, the success rate is 75%. There is a 75% chance of long-term success. So if you see, this is the first girl we showed. You can see how her occlusion has corrected and also how her profile has changed with the use of a reversible headgear. So now we are moving on to the orthodontic treatment options that are available for teens and for adults. So like I mentioned earlier, once the child is around 13 years old, and for adults, for mild to moderate orthodontic problems, we can attempt what we call orthodontic camouflage treatment. That is where we try to move the teeth to mask the underlying skeletal discrepancies. So this is a girl. She presented to us after her pubertal growth spurt, around when she was around 17, 18. So you can see that she has proclined incisors. This what we call a class 2 malocclusion. So we have treated her by extracting teeth. We have extracted 4 units, first premolars, 2 first premolars in the maxilla and 2 premolars in the mandible. And then we have moved the teeth. And we will, even though we are not able to sort of correct this underlying skeletal discrepancy, we can achieve a pleasing profile for the patient as well. If you can see from the top and the bottom, her post-treatment, we do see a improve in the profile as well by the movement of the teeth. Similarly, this is actually called a bimaxillary proclination, where the teeth have sort of both the maxillary and the mandibular teeth have proclined to mask the underlying skeletal class 2. So in this case also, we have actually extracted 4 units, and also because what we call her bimaxillary proclination was quite severe, we have actually used what we call temporary anchorage devices to achieve maximum retroclination of her teeth. And you can see the end result in the below photographs, and you can see how the profile changes with the movement of the teeth as well. So this is a similar case. This is a problem in the vertical plane. So this could be due to a persistent thumb sucking habit, which was not stopped at the right age, or it could be because of a skeletal discrepancy as well. But when and in the vertical plane also, when the problem is mild to moderate, we can use fixed appliances treatment to achieve to correct the malocclusion. So you can see we have again used fixed appliance treatment to obtain what we call a positive overjet and a positive overbite, both in the horizontal plane and the vertical plane. So just a word about aligners, because now there is a huge demand for aligner treatment. So this patient also, she had a class 3. She was again a bimaxillary procline case, and she had an anterior open bite as well. So she was treated with what we call aligner treatment, and you can see the end result. So if you all do have questions about aligners, like, now the technology is developed where we can achieve comprehensive treatments via aligner treatments as well. But of course, the cost factor plays a role, because there is the cost that you have to the cost factor is very high. The cost is very high for these appliances, and also the other factor is because these appliances, we have to rely completely on patient compliance. So so your patient selection is very important when it comes to aligners, because if your patient is going to be an uncompliant patient, you won't be able to achieve any result at all. So finally, we are moving to orthodontic surgery. So orthodontic surgery is actually for patients who have severe skeletal discrepancies in the anteroposterior plane, the vertical plane, and the transverse plane. So orthodontic surgeries are carried out generally after the completion of the growth for more complex skeletal disharmonies, which cannot be corrected by the movement of the teeth alone. So the treatment will involve combined surgical and orthodontic procedures. Here we see 3 patients. So the patient on the left, she has what we call a prognathic mandible. So she's a class 3. This is a high angle patient where she has a skeletal vertical maxillary excess plus a class 2. So she has problems in 2 planes. And the final patient, again, she has a class 2 with a low angle. So again, she has problems in 2 planes. So what are the maxillary surgeries that we perform to correct these jaw discrepancies? So for maxillary retronetism, we can do what we call a LIFO1 or a high LIFO1 maxillary advancement. And we do have, for when the problem is more severe, we can have bimaxillary surgeries where we bring the maxilla forward and the mandible back to correct maxillomandibular skeletal imbalances. So this is the first girl. So she had a single jaw surgery where she underwent a bilateral sagittal split mandibular setback, and you can see the end result. So which was corrected with a surgery. So a similar problem where the boy had a class 3 skeletal pattern, and he also underwent a bilateral sagittal split osteotomy where there was a mandibular setback, and you can see the end result. But then for these patients, they will have what we call a pre-surgical orthodontic phase, sorry, where we align the teeth so that the surgeon will be able to get the maximum movement of the jaws. And then afterwards also they will have what we call a post-surgical orthodontic phase where we try to settle the occlusion after the surgery. So a similar case here, you see the patient's intraoral photographs as well. So he also underwent underwent a bi-jaw surgery where he had a maxillary advancement plus a mandibular setback. So you see the elastics are in place to settle his occlusion after the surgery. So this is actually a cephalometric X-ray, and so when the patient first comes to us, we take a cephalometric X-ray, and then we do what we call a cephalometric tracing, and then we we identify which jaw needs to be changed, and then we do what we call that, like manually we do a pre-surgical mock-up surgery. Now, of course, there are 3D options which are available, but still cephalometric also plays a important role. So in the right, what you see is a patient who had after the surgery. So you can see the screws in place for he underwent a maxillary advancement plus a mandibular setback. So we do take a cephalometric X-ray after the surgery as well to ensure that the jaws are in the correct place. So this again, a class 3 patient, he had actually a facial asymmetry as well. So he had 2 problems in the, he had a problem in the anteroposterior plane plus the transverse plane. So he also underwent a bi-jaw surgery. So he's actually, we have not completed his treatment yet. So he's in the phase where we are settling his occlusion after the surgery. You can see the change in the profile pre and post after the surgery. So this boy had a problem in the anteroposterior plus in the vertical plane. If you can see, we call this a long face syndrome, where we see that the patient has a very long face. This could be because of a vertical maxillary excess. So in this case also, he will need a bi-jaw surgery. And an important point that we want to mention here is when you consider the anteroposterior, the transverse, and the vertical planes, the transverse growth for the maxilla and the mandible, for the maxilla and the mandible, completes first at the age of 15 to 16 years of age, and then anteroposterior growth continues until the patient is around 19 to 20 years of age. So you might see that, especially in class 3 patients like who have mandibular prognathism, sometimes we don't start treatment when the patient is around 16, 17. Sometimes the patient might come to you feeling quite distressed, but the underlying point is because if we intervene when the child is around 16, 17, the continuous growth will necessitate that where we will have to go for a second surgical procedures, and these are of course major surgical procedures. So that is why we wait until the growth is complete for such patients. So for vertical growth continues well beyond the age of 18. Now they say that it goes on to the early third decade of life. So for vertical problems, we have to wait until sort of the growth stops for the patient to intervene. Because attempting to correct with the movement of teeth alone during adolescence will be unsuccessful, as the original growth pattern is going to continue. So because this is a medical audience, and because we do as orthodontists do play a part in cleft care, we just want to mention little bit on the orthodontic role when it comes to management of patients with cleft lip and palate. So you know that the overall incidence for cleft lip and palate is about 1 into 700 in live births. But it's slightly higher in the Asian population, where we see about 1 into 500 births, especially in the Chinese and the Japanese populations for cleft lip and palate. So this is the standard treatment protocol. So when the child is presented, we have to have feeding management. And for patients with, not for all patients, but for patients who have bilateral cleft lips and palate, they will need a pre-surgical orthopedic phase before the cleft lip repair, which happens at around 3 to 5 months. So this will be decided by the orthodontist and the plastic surgeon or the maxillofacial surgeon who will be performing the cleft lip, because the cleft lip surgery, because if they cannot approximate the two sides, they will need the child will need a phase of pre-surgical orthodontics. And then after this palate repair will happen at around 9 to 12 months, and then the child will be sent for speech therapy. And then the child will need a phase 1 orthodontic phase if the child is having what we call an alveolar cleft as well. Not for isolated cleft lip patients, but for patients with cleft lip and palate, they will have an alveolar cleft as well. So the alveolar bone graft or the alveolar cleft repair should ideally happen at the age of 9 years. We say before the canine erupts. So these children will probably need a phase of pre-surgical orthodontics before the alveolar bone grafting as well. If the surgeon needs space, or if there are any teeth that needs to be moved in or out of the alveolar cleft area. And then after this alveolar bone grafting, the child will undergo the comprehensive orthodontic treatment phase during the age of 11 to 15 years. And finally, after the child is 18 years old, if there is an underlying skeletal discrepancy which needs to be addressed, they will need an orthodontic surgical phase, where they will need a phase 3 orthodontic phase. So here you see a patient, child with a cleft lip and a palate, who was operated, and then post-operative 8 years. These photos were given to us by Dr. Shriyani Basnayaka, so we want to give her the credit for providing us the photographs. And then you see this child with, if you can see, just before the alveolar bone grafting. So he will need a phase 1 treatment before the alveolar bone grafting. And this is a finished case. So finally, we just want to mention about the Sri Lanka Orthodontic Society. We do maintain a website where we have information for patients, and also in our website we do have mentioned all the institutions where patient can be directed for, especially in the government sector. Also for qualify, where you can find a qualified orthodontist in the private sector as well. So you can access the website. It's slots.lk. So you could you can also go and look, because we do have uploaded a lot of patient education videos with regards to orthodontic treatments that are available currently in Sri Lanka.
A question here which says, my child is 2 years and 3 months. She is sucking thumb during sleep. She has prominent upper teeth. At this stage, should I take treatment to correct teeth? Then trying to break her thumb sucking. So yeah, this is a very common thing that you see around 2 years, right? Child is still in decidual dentition phase. Therefore, and you don't need to intervene at this point. Child is not going to understand, but there is a advantage we do see in other countries because there's common use of pacifiers. Use of pacifiers does tend to stop the thumb sucking because pacifiers you can discontinue at the age of 3. And beyond that, studies say children do not continue to suck, whereas thumb sucking tends to continue beyond the age of 9 and all that for certain studies. So therefore, if you want to switch her, you can try switching her to a pacifier. And then and then at one point you can hide it or you can throw it away when she reaches around 3 years. Whereas thumb sucking, yes, it is a bit difficult. So you can wait until she gets to an age where she can understand and try all these non-dental methods first. Try to get her to stop. And if it is going beyond the age of 6 and 7, yes, we have to go for. That's when the permanent teeth are coming into the arch. Then definitely, yes, we have to go for habit breaking appliance therapy. Dr. Afka, over to you.
Yeah. Thank you, madam, for your time and the expertise. And we got a great knowledge regarding when to treat the problems and identify it early to get a good smile as well as a facial appearance.